You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that had, has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. I have Jay Shepard, the CEO of a company called Aravive. The website is ir.aravive.com. Aravive spelled ARAVIVE.com. Aravive is a clinical stage biotech company. They focus on developing innovative therapies that target survival pathways for cancer. So without getting into the specific receptors and pathways, which we'll talk about in a little bit, I just want to welcome Jay. Thanks for coming, Jay.
Thanks for having me, Richard.
Yeah, so tell me a little bit about the company and how the company's premise and focus came about, why cancer, and what particular types of cancer do you focus on?
Yep, sure. So Aravive was sort of born out of research that was done 4 or 5 years ago at Stanford under the leadership of a scientist by the name of Amato Giacchia, and he was the founder of Aravive. And the premise was that there's one of the fairly well-known mechanisms of sort of metastases is the what they call the axial gas-6 pathway. And what that means is that when the pathway, when it's a lock and key sort of mechanism, so, axial is a receptor in the body and gas-6 is a ligand. And when those two entities merge with one another, they cause to oversimplify, they cause cancer to metastasize, and they also can cause drug resistance. And so, over the last 10, 15 years, there's been a lot of work that's been done to try and shut down that pathway, to shut down and sort of short circuit the whole gas-6 axial pathway so that you can minimize drug resistance and metastases. And there's been a number of companies that have really focused on sort of shutting down the axial part of the equation. And there's been mixed results in terms of small molecules trying to sort of shut down the axial part of the gas-6 axial pathway. So what Amato Giacchia and his colleagues at Stanford did was, what if we can short circuit the whole process by using a biologic approach, very specific biologic approach to shut down the gas-6 pathway. And if you can figure out a way to bind gas-6, then the whole sort of lock and key mechanism, you short circuit the whole thing of the ligand and receptor sort of binding with one another. And so they did figure out a way to do that. And so what Stanford invented and developed was a process by which they've created what we would call an axial decoy. So, a gas-6 decoy. So what happens is you administer this product, it's called AVB 500. You administer it into the body, and what happens is that the gas-6 sees it, and it binds with that versus natural gas-6. And then thereby, when you bind it up, it short circuits the whole process. And if you bind up gas-6, then the body can no longer sort of bind the natural gas-6 to axial, and it shuts down the whole process. And so,
quick couple questions here. So, on cancer cells themselves, on the surface of the membrane, is that where this gas-6 receptor or ligand exists? Mechanistically, what's where?
Yeah, it is on the surface of the cell membrane. That's exactly where it is.
So certain cancers, it's not available on all cells, but cancer cells, for some reason, they change the expression of the cell, and then this receptor appears on the surface. Is that what happens?
Yes, there's a number of different cancer types. I think we believe that most cancers express or overexpress Gas6 and AXL, but there are certain cancer types that where Gas6 and AXL is, or Gas6, I should say, is highly expressed. So, cancers like ovarian cancer, pancreatic cancer, AML, triple negative breast cancers, head and neck cancer, and renal cancer, they all overexpress Gas6 highly. And so, it is expressed in virtually all cancers. There are certain cancers that, really overexpress it, and those are the cancers that I.
How does this cause metastases? Do the cancer cells express both Gas-X and AXL, and then through cancer to cancer cell communication, they're letting each other know, go ahead and find a new spot and metastasize, or what's the mechanism of metastasis through this ligand and receptor?
Well, I think some of these highly scientific questions probably would be best served by speaking with some of our scientists. But basically, like I said, most every cancer expresses Gas6 and AXL, and they're present on the surface of the cancer cells. And when they're expressed, they sort of cause a chain reaction. Once the Gas6 binds up with AXL, it causes a downstream effect of metastases by the epithelial cells become cancer cells, and then they start growing and metastasizing. And by administering our product and focusing on our biologic approach versus a small molecule approach, it basically shuts the process down effectively by going after the ligand versus the receptor. And so, from a very high level perspective, that's how our drug works.
So what does the small molecule drug do versus the biological solution that you created? I mean, so wouldn't small molecules bind to these receptors, or they just bind to each other? The AXL binds to the Gas6, but you're finding something else to step in there and bind to it instead. Is that what you're saying?
Yeah. So what I'm saying is that what the small molecules or the small molecule approaches do right now is they bind with AXL, whereas we bind with Gas6. So, and the problem with binding with AXL is that it's with a small molecule. It doesn't it doesn't just bind with AXL. It potentially can bind with AXL and other sort of AXL lookalikes, if you will. And so it has the small molecule approach. While it's shown to be effective in a number of settings, there's scientifically sort of belief that potentially the gas, going after Gas6 is more selective, because what Aravive has seen in their preclinical models, and now they've seen in the phase 1 study, which was in healthy volunteers, is effectively like a complete suppression of Gas6. And if you shut down the Gas6 ligand, then there's no way that AXL can be activated, as opposed to going after AXL with a small molecule. There is the potential that the binding with AXL is not as selective as the effect that you would get if you bound with just Gas6. So you're going after the ligand. We are going after the ligand Gas6 versus going after the receptor AXL, which is a small molecule.
So what happens? What was the preclinical model? Was it a mouse model, or what does it look like?
It was mouse models, and again, we have that is Aravive has data in ovarian and AML, in pancreatic, in renal cancer, and yeah, they were in rodent models.
So what happened in the preclinical setup? Did the mice already have metastatic cancer, and did it just stop communication between the original tumor and the metastases, or did they have just an original tumor and then it stopped it from spreading to other tumors, or what happened?
Yeah, the rodents that were injected with our compound had already had metastases, and what it did was it stopped or it reversed the metastases. And the ovarian cancer, for example, and this was what we call resistant ovarian cancer or resistant ovarian cancer cells in rodents. In 20 to 30% of the cases of the rodents, it actually cured the cancer, which is almost unheard of. But it is a preclinical model, and we have yet to see, we just started administering our drug in our phase 1B patient population of resistant ovarian cancer. That trial is undergoing right now. But again, the preclinical model in the rodents, they had resistant ovarian cancer, and it was already metastatic, and it reversed it, or shut it down, or cured it.
Why? I wonder what this signaling pathway is used for. So, what do the scientists imagine that it's used for? Why would it stop not only the metastases but the whole cancer in general?
Well, I think what the scientists at Stanford and other scientists across the world, I think the hope is that if you can shut down the axial gas-6 pathway, if you can shut down that process, which is a known culprit of creating metastases with cancer, if you can shut it down, you can either reverse or shut down the whole metastatic process. I don't know if that's answering your question, but that has been the hope and the quest, if you will, for the last 15, 20 years. And there's a lot of different approaches scientifically to shut down that known pathway. But the Aravive approach is the first approach that has gone after the gas-6 part of the axial gas-6 pathway. And so there are clinicians and scientists out in the communities of the world that believe that this may be, can't promise it, but this may be a best-in-class approach to shutting that pathway down. Yeah, it would for patients with metastatic disease. This would be a real significant breakthrough for them, and that's what we're hoping and praying that our product will be able to help with. We hope that all products will, any approach to shut down this pathway, we hope they all work. But we've got a unique approach, and it's patented, and we're the only ones that go after this sort of mechanism in the way that we do, which is to shut down the gas-6 piece of the equation.
So I just wonder, again, what's the role of this pathway? Is it for the cancer cells to communicate with each other so that they can have some kind of coordination and, survive in the body? And then by blocking this, maybe they're all acting solo, and that's why you have an uncoordinated cancer and the whole thing then is susceptible to the immune response? Or is it that this is communication only between the original tumor and the metastases? So I guess if it was, then you'd see the original tumor survive and none of the metastases survive. So I guess it must be, I guess, without knowing, is that this is involved in the cell-to-cell communication between tumor cells specifically. So they become uncoordinated and maybe weaker.
Yeah, I think, again, I'm not a scientist, and I don't want to pretend to sort of, answer your questions, which are good ones. I don't want to sort of give you any misinformation, but as I understand it, this process, this scientific process that's been developed out of Stanford, it stops the cancer cells from converting into metastatic cells. And the simple way to think about that is that cancer cells in the body will convert into cancer cells, and then cancer cells proliferate, grow, and expand in the body. And our drug, we believe, we hope that it shuts that process down from happening. So we don't have clinical results yet in patients, but what we think it will do is that it will, in many cases, it will stop the progression of the disease, and in some cases will reverse it. I mean, that's really the hope. And what that means is that you'll stop the cancer cells. They'll go from, kind of metastatic cancer cells back to normal, healthy epithelial cells. So in terms of, this agent will be, kind of used in combination with other chemotherapeutic agents. So it's, what we call an adjunctive therapy. At this point in time, we're not really testing it by itself to sort of cure cancer. It's used to make the cancer agents that are being administered right now in the cancer types I've mentioned. It's meant to be adjunctive, and it's meant to be sort of a helper therapy to make the chemotherapeutic agent more effective in doing their job of shutting down or slowing down the disease progression.
Right.
In some cases, you could get a complete reversal, and we're hoping that it may. In some cases, people will have what you call complete responses. In other cases, you'll get just responses, and the drug will be very, very effective and will keep people alive much longer. And ultimately, there's the potential of this drug to be used as sort of maintenance therapy, meaning that people. It's almost like AIDS, which is has become sort of a disease it has become almost a chronic disease. This type of therapy that we have, because it's such a safe product. It has virtually no toxicity at all in the body. Like people don't get side effects with this drug. This might very well be an ideal agent as a sort of a maintenance therapy drug that people could take almost indefinitely. But we have yet to be able to, kind of prove that hypothesis. But it's that kind of a drug, almost like it will work adjunctively with other drugs, and then potentially longer term, as we study this drug and develop it, it can also be used as a sort of a potentially a maintenance therapy.
That makes sense. So you tested the mouse model, and then the first step or stage of the clinical trial, what was that like, and what's the current stage that you're in? How's that different?
Yeah, so this last December, we started treating our first patients in what we call the phase 1B portion of the clinical development program for AVB 500. And we're testing the drug in resistant ovarian. So we're hoping to complete that part of the study, sometime in the second half of this year. And then we will go to, this phase 2 of the study. So right now, we have a number of patients that are enrolled that are, have had the drug administered, and it's being administered with a drug called either Doxil or Taxol, sort of, the resistant ovarian cancer setting. And so what we're hoping is that patients will survive longer, and patients will, and then we'll also see that patients, what you call progression-free survival, which means obviously the amount of time from when the drug is administered to the time that the disease reoccurs, that we're hoping that our drug will make that period of time much longer, that they slow down the progression of the disease. And then obviously we're hoping that, the patient's overall response rates are higher, and, ultimately that they're surviving a longer period of time. And that's what we're looking for in the phase 1B resistant ovarian cancer study. And then the phase 2 will basically be looking at the same population, except it'll be a controlled study, and it will be randomized, either being combined with Doxil or Taxol against Taxol and placebo, and Doxil and placebo, so that we can see whether or not our drug made a difference in those settings. That would be the phase 2 part of the study, which would start again in the second half of this year.
Why wouldn't you do a control of your drug and no chemo?
Because anybody with resistant ovarian cancer, that you obviously would treat them. So that wouldn't be fair to the patients not to treat them with drug, which is typically Taxol or Doxil. So it wouldn't be right for us to sort of test it against nothing, because that wouldn't be fair for the patient. So the standard of care is either Doxil or Taxol. So they will either be in that arm of the study, or they'll be in the arm of the study where they get those drugs plus our drug. So, any of the patients in our study, they're not giving up anything. They're just participating in a clinical research study that is aimed at trying to figure out whether or not the approach of adding our drug is helpful to their disease progression or not.
Well, chemo is, I guess you can call it, proven. It's effective in some people, not in a lot. And the whole reason you have chemo-resistant cancers is because of the chemo applied and the nature of cancer changing. How are you ever supposed to separate the effects of this drug and chemo if you're not allowed to test it alone?
Well, I think physicians historically have expected to get a certain set of results when you give, just say, Doxil or Taxol. I think they expect to get a certain result in a resistant setting. And so let's say physicians expect to get 3 months of progression-free survival on average when you give either Doxil or you give Taxol, any resistant setting. What we're hoping is that when you test, kind of our drug, when you combine it with Doxil or Taxol, we're hoping that we can improve on that progression-free survival of, say, on average 3 months by adding our drug in. And I think it's a pretty direct comparison of, if physicians historically over the last X amount of years have gotten 3 months of progression-free survival on those drugs, and if you add our product and they get, let's just say, 5 or 6 months of progression-free survival, I think physicians will be able to draw a direct correlation and say, as long as the study's powered right and there's the proper number of patients, i.e. being powered right, physicians would look at that and say that's definitely an improvement. And I think patients we're hoping, it would be a win-win for everybody. So that's the direct comparison that you would do. You would never sort of withhold the standard of care, whatever that standard of care is, from patients in the clinical study because that would be unfair to patients. And the reason that you can add our drug safely and effectively is that sometimes when you add other sort of anti-cancer or kind of therapeutic options to existing chemotherapy, you get additive toxicity, meaning side effects. And then it becomes sort of a balancing act of, is it worth, adding all the toxicity for, whatever benefit you're hoping you might get. With our drug, there's not really a trade-off in the sense of you're not adding toxicity. What we're hoping is that we're giving them another agent and they're getting sort of better efficacy without adding the side effects.
But that's the sad thing. If your drug works without any side effects, why do you have to add the chemo, which has all kinds of terrible side effects? Let's say your drug works. Then if someone wants to do something else to add to it, let's say your drug and chemo become the standard of care. Now they have to piggyback on top of those two and do a third in order to get their drug through. It's kind of like, I don't know, it just seems ridiculous to me. If they're willing to do a trial, and I know this is not your fault, if they'll approve a trial that has, the chemo and placebo, why isn't that unfair to the patient? Just because this is not yet proven, and it just seems to put anything besides chemo at a disadvantage because they're forcing it to be given along with it when that may not even close be the right solution. Maybe another drug with chemo does have terrible side effects, but alone it would be fine. It would work better, but they won't allow that.
Yeah, well, we haven't studied our drug yet, so whether it'll get a better effect by itself versus some of the other drugs that are what you call platinum-resistant setting. For example, we're talking about platinum-resistant ovarian cancer. So we don't know if our drug by itself, we haven't studied that way yet. So I think in cancer therapeutics, when you develop drugs, what you want to sort of do is sort of be able to add on to what physicians are already doing, getting results. Because there aren't a lot of drugs out there that when you start getting, kind of resistance, in other words, drugs stop working as effectively as they did earlier on when you have early stage cancer. When you get to that kind of setting, there's really not a lot of drugs that are super effective, but there are drugs that do prolong survival and they do knock down the cancer. And so physicians aren't going to stop using those drugs. They're not going to stop using those drugs because they're effective. And yeah, they definitely have side effects, and chemotherapeutics they're difficult for the patients to tolerate in many cases. But they still in many cases will prolong their life. And, given the option of prolonging your life versus not taking anything at all, I think, I don't want to speak for patients, but I think, historically patients have opted to take the drugs that will prolong their life, even though they have side effects. And then our sort of value proposition for our product is you can add our drug in and you're not giving anything up. You're not sort of replacing the efficacy of the chemotherapeutic agents, but what we're hoping to do is turbo boost them, sort of add incremental efficacy to what the baseline drugs are offering them. And so I think we would all agree with you, Richard, that we wish that there were drugs that patients could get that didn't have any side effects and that, just cured their disease. But we haven't found those drugs by and large. I don't think those drugs we're still trying to discover those drugs. In certain cancer types, certain types of leukemia, they have figured out how to, cure certain types of cancer. But the ones that we're sort of trying to help out with, our first sort of foray is a resistant ovarian cancer. I don't think the world has discovered drugs that are curative yet. So what you're left with then is, can something be added into existing drugs that will have an incrementally beneficial effect to the patients? And we believe, although we haven't proven it yet, we believe that our drug has the potential to really help those existing drugs out. But you wouldn't want to take those drugs away unless you found something that could sort of just, cure the disease. And I'm afraid at this moment, we don't have evidence that our drug by itself will cure it. And I don't think there's really any drugs out there that have been able to show that yet. So again, the hypothesis or the hope is that, and the prayer is that we will be additive to the drugs that are already giving them a beneficial effect in terms of efficacy. So that's.
Well, how would you prove it that your drug may have positive effects on its own? Let's say you do it and hopefully the trial works and works well. Mm-hmm. How would you ever then say, well, why not just try the drug alone? Maybe it'll work so well that we won't need chemo. Or is that just not allowed?
Well, I think it's, drug development is sort of always a stepwise sort of process. If you think about any therapeutic area, you take it step by step. And so typically what you do is you develop your drug and you test it in patients who are, really having a hard time or are not responding to conventional drugs. And you start there. And then as the drug sort of shows that it can slow down or reverse or stop disease progression, then you start using it earlier and earlier, meaning, first line, second line therapy versus, say, second or third line. Does that make sense?
Yeah, I just, like I said, I'm just wondering whether, but okay. It makes sense as far as it can go, but okay. So what's the timeline? So you said by middle of this year, you're going to be in phase 2B, or, what's the timeline for phase 2, 3, and then I don't know if there's a 4 until it actually comes to the market.
So the timeline would be that phase 2 would start sometime in the second half of this year. So sometime between July and December of this year, we would start our phase 2 trial, and then we expect to see results of that trial sometime toward the end of 2020. And then after you're done with your phase 2 trial, then you go to your pivotal trial or your phase 3 trial, which would be sort of, a larger, it would also be a randomized trial that, we would then take that data and submit that to the FDA to try and get them to approve this drug so it could be used, in the resistant ovarian cancer population. It would be available, what you say, commercially. So that's more or less the timing insofar as the resistant ovarian cancer setting.
So if things work out well and the drug shows good efficacy, how long would it be, ballpark, do you think, until it's available as a therapy to the general public?
We haven't really given the public, we don't know exactly what the timeline looks like in terms of the completion of the phase 3 trial, because that's obviously a larger trial, but, it could be, it'd be sometime before 2025. So 2025, it would be sometime before then, probably, hopefully, several years or a couple of years before that, but we haven't disclosed exactly when that would be. And the phase 2 trial has to start accruing, then we have to complete it, then we have to sort of assess what the data and the results, how the data looks, and then you start your phase 3 trial. And then that, takes a year or two to accrue, meaning enroll patients, getting the results of that. So, if you can imagine that would be in the early 2020s.
Okay, very good. So what's the best way for folks to find out more, get in contact, ask questions, etc.?
I think, they can go on our website. They can also look up, it's called clinicaltrials.gov, is, sort of the standard place where you can find information on clinical trials on all kinds of therapeutic trials that are undergoing. So they can contact the company directly by looking at, Aravive.com, or they can go on clinicaltrials.gov and on the web in general. And I think the website, there's obviously contact information for the company and can triage any questions folks would have into the appropriate scientific and medical folks.
That's great. Well, Jay, thank you for coming. I really appreciate it.
Okay, Richard, thank you for your time and your questions, and hopefully the information was helpful.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.